Half of the people who die from a heart attack this year will have had a completely normal cholesterol test. Normal. Clean. Nothing to worry about, their doctor said. I've stood in the operating room with those patients. I've held their hearts in my hands, and I can tell you, the warning signs were there. We just weren't looking at the right numbers. My name is Dr. Kevin Adewale. I'm a cardiac surgeon. In over 2 decades of operating on human hearts, I've learned one thing that most routine checkups will never tell you. The standard cholesterol test? It's a starting point, not a finish line. Today, I'll show you the 3 tests that actually tell the truth. Tests that give a far more honest picture of what's happening inside your arteries, and that you can ask your doctor for at your very next appointment. If you're over 60, this video may be the most important 20 minutes you spend this month. Let's get into it. The standard cholesterol panel has been around since the 1960s. Back then, it was a genuine breakthrough. Scientists figured out that fat buildup in the arteries was connected to heart disease. And suddenly, doctors had a number to measure: total cholesterol, then LDL, then HDL. For decades, that was the best tool we had, and it helped millions of people. But medicine doesn't stand still. And what we've learned since then has changed everything about how we assess cardiovascular risk. Here's the problem with the standard test. It only measures the amount of cholesterol floating in your blood. What it doesn't tell you, and this is critical, is why that cholesterol is dangerous, or whether it's dangerous at all. 2 people can have identical LDL numbers and completely different levels of risk. One is fine, the other is heading toward a cardiac event. So how do you know which one you are? Here's a statistic I think about every single time I walk into an operating room. Roughly 50% of people who suffer a heart attack have LDL cholesterol levels that fall within the normal range. 50%. That's not a rounding error. That's half. Studies from major cardiology journals, including the American Heart Association, have confirmed this pattern again and again. Normal cholesterol does not mean a safe heart. It never did. We just didn't have better tools to look deeper. Now we do. Does that mean your cholesterol test is useless? No, it still matters. Think of it like a weather forecast that only tells you the temperature. Useful, but if it doesn't mention the storm coming in from the west, you might leave the house without a coat. The 3 tests I'm going to walk you through today are that storm warning. They measure what the standard panel completely misses. For people over 60, when arteries have had decades to quietly accumulate damage, these tests become even more important than they are at 40. Here's the question I want you to hold in your mind right now. When was the last time your doctor ordered any of these 3 tests for you? If the answer is never, you're not alone. Most people have never even heard these names. By the end of this video, that changes. Test number 1, CRP, the fire alarm inside your arteries. Have you ever seen what happens to a pipe that's been corroding from the inside for years? The pipe doesn't fail because it got thicker walls. It fails because the damage makes it brittle. And one day, a crack forms. That's the key. That's almost exactly what happens in your arteries when inflammation is left unchecked. CRP stands for C-reactive protein. Your liver produces it whenever there's inflammation somewhere in your body. And most people don't know what chronic low-level arterial inflammation really means. It's one of the primary triggers that turns a stable plaque into a dangerous one. Let me explain what I mean. Not all plaques are equally dangerous. Some are stable, calcified, they don't move. Not ideal, but not an immediate emergency either. Others are soft, inflamed, and unstable. Those are the ones that rupture. And when a plaque ruptures, your body responds by forming a clot. That clot can block an artery completely within minutes. That is a heart attack. That's the moment we're working to prevent. High-sensitivity CRP, the specific version of the test you want, measures the level of that inflammatory activity in your blood. Below 1 milligram per liter, low risk. Between 1 and 3, moderate risk. Above 3 is where I start paying close attention. An elevated CRP doesn't automatically mean your heart is in danger. It can be raised by a recent infection, arthritis, even a long international flight. Context matters. Your doctor will look at it in context, not in isolation. But if your CRP has been consistently elevated for months, that's a conversation worth having, because that ongoing inflammation is doing quiet, cumulative damage. The earlier you catch it, the more options you have. The good news: CRP responds to lifestyle changes. Regular moderate exercise is one of the most powerful anti-inflammatory tools we have. Not marathon training, not extreme diets. Consistent, moderate movement. 30 minutes most days. An anti-inflammatory diet helps significantly too. Think omega-3 fatty acids. Salmon, sardines, walnuts, flaxseed. More colorful vegetables. Less processed food and refined sugar. Good sleep, 7 to 8 hours, has a measurable effect on inflammatory markers. Chronic stress keeps CRP elevated regardless of everything else you do. I've seen patients bring their CRP down significantly within 3 to 4 months, just by making consistent, realistic changes. That's real. So ask your doctor for a high-sensitivity CRP test, not just CRP. Write that down. Simple blood draw, often covered by insurance. And it tells you something the standard cholesterol panel never could. That is test number 1. Let's move to number 2. Now here's a test that genuinely surprises people. And I'll be honest, it surprised me too the first time I really sat down with the research. Lp(a), pronounced Lp(a), is a type of lipoprotein. Think of it as a close relative of LDL, the so-called bad cholesterol. But Lp(a) has an extra protein attached that makes it particularly aggressive at building up in artery walls and promoting clotting. Here's what makes it completely different from almost everything else we've discussed. Your Lp(a) level is almost entirely determined by your genetics, not your diet, not your exercise habits, not whether you've been eating well for 20 years. It's set by the genes you were born with, and it stays relatively stable throughout your entire life. Roughly 1 in 5 people, 20% of the population, carries genetically elevated Lp(a), and most of them have no idea. Their LDL looks fine. Their total cholesterol looks fine. Their doctor says, "You're doing great." Meanwhile, elevated Lp(a) is silently accelerating plaque formation in the background. I've had patients in their mid-60s, fit, healthy, non-smokers, normal LDL, and they still ended up in my operating room. When we looked back, elevated Lp(a) was sitting there like a fingerprint, had been elevated their entire adult life. Nobody had ever tested for it, not once. So what do you do if your Lp(a) comes back high? I want to be straight with you here, because honesty is more useful than false comfort. Diet and exercise will not significantly lower your Lp(a). That's just the science. What you can do is manage everything around it. Keep your LDL and CRP as low as possible. Control blood pressure. Don't smoke. And talk to a cardiologist about whether more aggressive monitoring, or in some cases, medication, makes sense for you. There are also emerging medications specifically targeting Lp(a) in late-stage clinical trials. The picture is changing, but right now, know your number. The Lp(a) test needs to be done once, maybe twice in a lifetime. It's that stable. So if you've never had it done, don't wait. Ask your doctor. Say these exact words. I like to check my Lp(a) as part of my cardiovascular risk assessment. If they push back, ask why. You deserve a clear answer. That is test number 2. Test number 3, Apo B. In my opinion, and I'm not alone in this, Apo B is the most underused cardiovascular test available to patients today. Let me use an analogy that makes this click immediately. Imagine a busy highway. Your standard LDL test measures how much cargo is being carried on that highway. Apo B counts the actual number of vehicles on that highway. And here's why that distinction matters enormously for your heart. You can have a light load spread across 100 trucks, or the same weight packed into 20 massive ones. The highway looks identical by the cargo measurement, but the risk of a collision is completely different depending on how many vehicles are on the road. Each particle of LDL, VLDL, and IDL carries exactly 1 Apo B molecule on its surface. 1 particle, 1 Apo B. So when you measure Apo B, you're counting the actual number of dangerous particles in your bloodstream, not just the weight of the cholesterol they're carrying. Particle count, it turns out, is a far stronger predictor of cardiovascular risk than LDL cholesterol concentration alone. Here's a situation I see more often than you think. A patient comes in with an LDL of 110, borderline, but not alarming. Their doctor isn't particularly concerned. But when we run their Apo B, it comes back elevated. What exactly does that tell us? There are a lot of small, dense LDL particles circulating in that bloodstream. And small, dense particles penetrate artery walls more easily. They're more prone to oxidation, more likely to contribute to plaque. They're the ones that do the damage. The reverse situation also happens. Some patients have an LDL that looks high on paper, but their Apo B is actually quite low. Fewer particles, lower actual risk than the LDL number alone would suggest. The standard test was given an incomplete and potentially misleading picture. The target for Apo B, below 90 milligrams per deciliter for average risk adults, below 70 for those with known heart disease or diabetes. The Apo B test is a standard blood draw. No fasting required in most cases. So there it is. High sensitivity CRP, Lp(a), Apo B. Write those three names down. Now here's where it gets genuinely interesting. These three tests don't just matter individually. The combinations tell a story. Let's walk through real patterns I see in clinical practice. Scenario 1. Your CRP is elevated, your Apo B is high, and your Lp(a) is normal. That tells us there's active inflammation and a high particle burden. The good news, both of those things respond to intervention. Lifestyle changes, possibly medication, close monitoring, these can meaningfully shift that picture. It's a wake-up call, but one with clear action steps. Scenario 2. Your CRP is normal, your Apo B is normal, but your Lp(a) is elevated. On the surface, things look okay. But elevated Lp(a) means there's a genetic baseline risk that isn't going away, ever. The strategy here isn't panic. It's precision. Keep everything else optimized. Have a frank conversation with the cardiologist about monitoring frequency. Scenario 3. And this is the one that concerns me most. All three elevated. High CRP, high Apo B, high Lp(a). In that situation, the standard cholesterol panel might look perfectly acceptable. But the full picture tells a very different story. That combination warrants immediate specialist attention, regardless of what the LDL says. That particular combination changes everything about your risk profile. These tests aren't about frightening you. They're about giving you information precise enough to act on. Vague reassurance isn't protection, it's delay. Knowledge gives you options. And the earlier you have that knowledge, the more choices you still have available to you. I hear this from patients all the time. I tried to ask about extra tests, and my doctor just said my cholesterol was fine and moved on. I understand that frustration. Appointments are short. Doctors are busy. And if your standard panel looks okay, the conversation closes before it really opens. So let me give you the exact words to use. Say this: I'd like to discuss adding 3 tests to my next blood draw. High sensitivity CRP, Lp(a), and Apo B. Given my age, I think it makes sense to get a fuller picture of my cardiovascular health. That's it. You're not challenging your doctor. You're not self-diagnosing. You're asking for a conversation as an informed adult who takes their health seriously. A good doctor will engage with that. They may have clinical reasons to prioritize one test over another, and that's a perfectly valid response. What you're looking for is a real discussion, not a dismissal. And if you feel genuinely dismissed, it may be worth seeking a second opinion, especially if you're over 60, have a family history of heart disease, or carry any existing cardiovascular risk factors that you know about. You have every right to advocate for your own health. Don't let a 10-minute appointment stand between you and information that could change your life. Let's be practical for a moment, because giving you a scary number with no plan is not helpful. So here are your actual levers. CRP responds well to lifestyle. Regular movement, 30 minutes of moderate activity most days, is one of our most powerful anti-inflammatory interventions. An anti-inflammatory diet helps significantly. Omega-3 fatty acids, salmon, sardines, walnuts, flaxseed. More colorful vegetables, less processed food. Good sleep, 7 to 8 hours, has a measurable effect on inflammatory markers. And chronic stress, left unmanaged, keeps CRP elevated regardless of everything else. Apo B also responds to intervention. Dietary changes, reducing saturated fat, increasing fiber, can meaningfully lower particle count over time. Statins and other lipid-lowering medications are very effective at reducing Apo B. Weight loss, where relevant, helps too. This number genuinely moves. Lipoprotein A is the honest exception. Diet, exercise, and most current medications will not significantly change it. That can feel discouraging, I understand that, but here's how I reframe it for my patients. Knowing your Lp(a) is elevated means you can be more aggressive about controlling everything else. You compensate where you can. You watch more closely. Think of it like driving in unpredictable weather. You can't control the weather, but you can make sure your brakes are perfect, your visibility is clear, and you're paying full attention. That is the mindset. Here's something I want to address directly, because it catches a lot of people over 60 genuinely off guard. Many assume that because they've been getting annual checkups for decades and their cholesterol has always looked normal, they're in good shape. They've done everything right. They've been responsible. And then I show them their Apo B, and the picture changes. Here's what the research tells us. As we age, the number of dangerous particles tends to increase, even when LDL stays completely stable. Hormonal changes after menopause can significantly raise Apo B and Lp(a) levels. Insulin resistance, which becomes more common with age, drives small, dense LDL particle production upward. Chronic low-grade inflammation tends to increase with age, even in otherwise healthy people. The risk profile of a 65-year-old is genuinely different from that of a 45-year-old. Yet the normal ranges on most lab reports were established using data from broader adult populations. They don't always reflect what optimal looks like for someone in their 60s. This is why cardiologists increasingly argue that cardiovascular risk conversations need to be more individualized and more proactive as patients get older, not less. Does this mean you should be alarmed? No. It means you should be informed. Alarm paralyzes. Information empowers. There's a significant difference between those two things. Here's what I need you to really hear. I've been a cardiac surgeon for over 2 decades. I've performed thousands of procedures. And the question that never leaves me, the one I carry home after every difficult case, is this. Could this have been caught earlier? Sometimes the answer is no. Sometimes the disease moves fast and quietly, and there was genuinely nothing to be done sooner. But more often than I'd like to admit, the answer is yes. I think about the patients who came to me after years of clean cholesterol tests, years of being told everything was fine, years during which their CRP was quietly signaling inflammation that nobody measured, years during which their Apo B particle count was climbing, while their LDL stayed conveniently normal. Years during which elevated Lp(a) was accelerating plaque formation in complete silence. The damage doesn't announce itself. It accumulates, slowly, consistently, invisibly, until one day it isn't invisible anymore. The gap between feeling perfectly fine and a cardiac emergency can be remarkably small. Not because heart disease develops overnight. It doesn't. It takes years, sometimes decades. But because the warning signs were in the bloodstream the entire time, we just weren't running the right tests. That gap between what the standard panel shows and what's actually happening is exactly where these 3 tests live. CRP tells you whether the fire is burning. Apo B tells you how heavy the traffic really is. Lp(a) tells you whether you're carrying a genetic load that needs its own strategy. Together, they change the entire conversation about your heart health. I've seen patients get these results, make targeted changes, follow the right specialists, and genuinely alter the trajectory of their cardiovascular health. Not by doing something radical, by knowing, specifically, accurately, honestly, what they were dealing with. That is what modern preventive cardiology looks like at its best. Not waiting for symptoms, not reacting to emergencies. Acting on information while you still have time and choices on your side. You're watching this because you care about your health. That already puts you ahead. Now take the next step. So let's bring this home. 3 tests. High sensitivity CRP, your inflammation alarm. Lp(a), your genetic baseline. Apo B, your particle counter. Before your next doctor's appointment, write down these 3 names on a piece of paper. Put it in your wallet. Take it into that appointment. Ask for the conversation. 1 piece of paper, 1 conversation. That's the entire barrier between where you are now and a complete picture of your heart health. Now I want to hear from you. Have you ever had any of these 3 tests ordered? Drop your answer in the comments below. If this was useful, please share it with someone you care about. A spouse, a sibling, a friend who keeps putting off their annual checkup. Take care of your heart. And remember, everything I've shared today is general medical information. Your situation is unique. Please take this to your own doctor before making any changes.